Hello and welcome to today's event. I'm Carol Feig of the Answers Media Network. Thanks for joining us today for a conversation with industry leaders we've brought to the virtual table to discuss the current state of telehealth and what the future may hold. This event is sponsored by Vivify Health, the leader in connected care management. Learn more about Vivify Health at www.vivifyhealth.com. And now I'll introduce our moderator and our panelists. Our moderator for this event is our own Jim Tate, founder and president of EMR Advocate and the host of the Tate Chronicles on Healthcare Now Radio. Jim is a healthcare journeyman with over 20 years of experience across healthcare delivery, IT, and compliance. And on his bi-weekly radio show, explores emerging technologies that hold potential to bring beneficial disruptions to healthcare. Joining Jim as our first panelist is Rob Hevesy, who is a Senior Director of Connected Health at HIMSS and Managing Director of the Personal Connected Health Alliance. His focus in these roles is on the issues related to connected care health, including RPM, telehealth, patient engagement, and interoperability. Welcome, Rob.
Thank you.
Now I'd like to introduce Karen Joyce, who is the Vice President of Clinical and Virtual Operations with Trinity Health at Home, where she leads the national footprint of the THAH Virtual Care Center, as well as regional home care, hospice, private duty, and community-based palliative care operations in the states of Michigan, Florida, and Georgia. She has been a passionate leader of home-based services for 30 years. Karen, welcome aboard.
Thank you.
And last but not least, I'd like to introduce Bill Paschall, who's the Vice President of Business Development for Vivify. He is a subject matter expert on industry policy, reimbursements, trends and market drivers impacting the growing demand for telehealth and RPM, and has served on the American Telemedicine Association as a board member, as chair of the Industry Council, and is current chair of the Remote Patient Monitoring Special Interest Group. Hi, Bill.
Hello.
Welcome.
Thank you.
So in the next hour, our moderator and panelists will be touching upon and discussing these topics. Of course, the discussion today is fluid and may explore some areas greater than others. So now just sit back and I will turn the conversation over to Jim and our panelists.
Great. Thank you so much, Carol, and welcome to our guest. I'm really excited to be here today because this is a topic, it's like a diamond with many facets when we talk about telehealth. There are the potential use cases, there are best practices, there's issues around reimbursement, and there's also just around the hardware and software aspects and devices. So I'm looking forward to kind of touching on all those topics. And the crew we have on board today has extensive background that really covers all those particular things. Karen, I'd like to start with you first, if you don't mind, around the concept of use cases. Of course, telehealth, whether it is a virtual encounter or remote patient monitoring, that concept and that functionality has been around for a while. But in March of 2020, when the emergency pandemic, COVID pandemic hit, providers across the country had to scramble to do something, and they were looking for best practices. You've been involved with this world for quite a while, a lot of experience. So I'd like it if you'd let our audience know a little bit about the virtual care center that you run out of Trinity, the background of it, and what kind of patients you take care of.
Sure. So in 2017, Trinity Health at Home received an innovation grant from Trinity Health to start remote patient monitoring and partnered with Vivify Health. And the goal initially was really for us to assist our hospitals in decreasing the penalties they were paying for readmissions of patients in those penalty diagnoses. So we placed remote monitoring across the country on our Medicare population who had heart failure, COPD, diabetes, pneumonias, and sometimes joints if they had comorbidities, to really begin what we felt was going to be part of a robust remote monitoring platform. Along with that, we stood up a 24/7, 365-day a year virtual care center staffed by an all-RN staff licensed in all of the states that we serve across the country in order for them to be able to monitor the daily biometric alerts that were coming up, provide coaching calls on these serious illness to these individuals under our skilled home care, and also be able to receive orders from physicians when those alerts generated a need for an update to the plan of care. And we had huge success with that and dropped our readmission rates into the single digits across the country. When the pandemic hit, we expanded that use to all patients in our home care and hospice programs at Trinity Health at Home that were COVID positive or COVID pending. We added our Home Care Connect kits into each of their homes. And for our home care patients with COVID, it was really to identify those potential respiratory issues that came up often when they were post-acute care. For our hospice patients and families, it was to really not necessarily be as much concerned about the biometrics, but more to decrease their social isolation. So with our Vivify product and the way that we utilize the virtual care center, we can add a family member into the care team and they could have a virtual visit with that hospice patient if they were states away, or the patient lived in a facility and they didn't at that time wasn't open to visitors. So it really, we felt like met our need to provide quality care through a different really media almost than the face-to-face visit.
One of the things you mentioned there, Karen, is the really driver from the reimbursement side for hospitals to reduce readmissions. So they were really stimulated, for lack of a better word, to track those patients that were discharged with specific diagnoses to make sure they weren't readmitted within 30 days. So
Right.
There was a real push for that, and that was an obvious financial benefit to those who were paying for those services, Medicare, essentially. The whole area of reimbursement for these services, whether it's remote patient monitoring or episodic virtual visits, with the, and I don't know, Bill, maybe you can weigh on this, when the national emergency was declared, the steps were taken to have parity between those virtual visits and in-person visits certainly for ambulatory encounters. Is that, where are we with that? Does that continue? Is that going to continue? What's the status of the reimbursement?
Yeah, so Karen, if you don't mind, I'll go ahead and weigh in on that. So when the COVID pandemic hit, federal government was pretty quick to introduce waivers for telehealth. They were called the 1135 waivers. And over the course of 2020, there were 144 codes that were enabled under these telehealth waivers. So as you said, for them to pay the same as in-person care utilizing telehealth, and it was very broad. Really accelerated the growth of telehealth here in the United States, and along with that, remote patient monitoring. And we saw the incredible growth of companies like Teladoc and Amwell and others in that space, even IPOs, based on that explosive growth. And we currently are still in that public health emergency, so those codes remain viable. And as we see the Delta variant rising and maybe another possible variant after that. What I've heard lately is that there's an expectation that the public health emergency will last at least until January 2022 and likely well into 2022. So all of those codes remain viable for that good utilization of telehealth. The most prominent things was it was an elimination of originating site requirements and geographic requirements. So those telehealth consults can be anywhere at any time from any location. So the home was added and any mobile location. And so right now, everyone expects that at some point the public health emergency will end. Now what? You might have heard the term the Telehealth Cliff, where if nothing happens legislatively, there's an expectation all of those 144 telehealth codes will go away, and there'll be a drastic reduction in the ability to provide telehealth, even if there's consumer demand, and get reimbursement for that. But there are American Telemedicine Association right now is tracking about 25 different bills. Most of them relate to permanent elimination of originating site restrictions, which would really enable telehealth across the U.S. It would alleviate healthcare disparities, for example. So most of them deal with that. Probably the Telehealth Modernization Act is maybe the most common one that people have heard of. But that is almost every bill that's currently being tracked by American Telemedicine Association has bipartisan support and bipartisan sponsors. So we're really fortunate to be in a segment of U.S. industry, if you want to call it healthcare and industry, that still has very strong bipartisan support. So it looks good for a lot of these things, but you never know in today's political environment how soon some of these things will pass. So we're seeing that at the federal level. Some states are taking things into their own hands to make these telehealth waivers permanent. I think New York and Florida are probably the first two examples of that, but we're seeing that also.
I think it's a perfect example, too, of the disruption that the pandemic has brought to our industry. We had to think differently to provide care. So what Bill's mentioning, too, what has helped for home care has certainly been the face-to-face requirement can, under the waiver, be performed via telehealth visit. And it's enabled hospices to have social workers, chaplains, those ancillary services still continue care in a telehealth environment too. So that, you know, it's moving us forward a little bit faster.
Jim,
Go ahead.
if I could throw some out there, I think buried in your question is the existential problem we're facing right now. When we look, at a broad swath of the market, we have what happens in Medicare, right? Telehealth has some very specific rules and regulations that Bill outlined excellently regarding originating sites and other things. And everybody's afraid we could revert back to that. We have a lot of private sector. In fact, the majority of our healthcare is paid somehow through private payers, either self-insured employers or a variety of other plans. And there's a tension setting up right now. And it revolves around parity, which you asked about, and I'm not sure we really explored. As part of the public health emergency, as part of the disruption of care that Karen just talked about, physicians were facing a revenue cliff, right? Patients were not coming into the office, couldn't bill traditionally, practices were going under. There were GoFundMes for small practices, which is unheard of, I think, in a nation like the United States. So a number of states and other entities in the federal government stepped up to pay for telehealth at parity to try and fill in that revenue hole. The tension lies with the fact that a lot of private payers, self-insured employers, and people were looking at teletechnologies, not just televisits, but remote monitoring and other technologies to drive the cost of care down, right? And that's the tension that we're all dancing around in the middle of our legislative discussions right now. Nobody has an appetite, I think. My personal opinion is that we will not see parity of payment continue. I don't think there's an appetite in Congress on the Medicare level to see telehealth layer on top of traditional services. I think there's an appetite to see telehealth displace traditional services to try and drive that cost of care down. You can Google topics such as, private insurer, telehealth, et cetera, and you'll find a number of private insurers who are pushing back strongly in states with lobbyists and others to say, we will not support parity legislation. Right? We have to use this as an inflection point to drive the cost of care down. And when we talk about consumers, in a survey that HIMSS did on consumers, broadly speaking, most consumers say they value a telehealth visit less than they value an in-person visit. And as insurance plans change and put pressure on people to cover more out-of-pocket costs, they want to pay less out of pocket for a telehealth visit than they did for going in the office. So I think the parity question is a really difficult one we're going to have to wrestle with. And my gut tells me the momentum's on the side of a weird, odd coalition of business leaders, some congressional budget hawks, some states facing budget crises in Medicare, and other people who are going to look at this as a chance to try and push down. And I think Karen, in her initial remarks and some of the stuff that Vivify does really highlights an area where we see a difference, right? That reimbursement, that readmission penalty has been around for a long time for heart failure and COPD. And it shows us the power of how an industry can adopt these solutions when they are sort of on the hook for those ongoing costs, right? So by changing from fee to service and looking at more of the accountable care that we tried to get with those readmission penalties, we saw a broader adoption of these technologies once, healthcare providers face that pain. So I think the parity question is really where the argument's going to be over the next few months and years. I agree with Bill that we're going to punt this well into 22. We'll get to midterms. It'll punt beyond that probably. But that to me is the core of the problem.
Well, to take a step back and just view this, I guess, from a cultural perspective, the technology for telehealth encounters, not talking about remote patient monitoring, but just virtual encounters has been around. It was there. I think probably a small subset of providers were actually using it. And then in March of last year, literally in days, if not maybe a week or two, folks had to start using something. So they grabbed anything they could. The government said you can essentially use 2 Dixie cups with a string, and we're not going to penalize anybody. We're not going to enforce any HIMSS regulations because of this emergency. And so I think Rob used the term, they were forced into this technology, but they certainly had to jump in the deep end of the pool. And they may be backing off now, but it seems like there's familiarity with that concept. I mean, folks kind of know how to do it now, but patients also kind of know how to do it somewhat. So there was a learning thing there. But as far as the reimbursement, let's not talk just for a minute about the virtual visits. Let's talk about remote patient monitoring, because to me, that seems like a giant new way of delivering healthcare outside of an inpatient environment. And that can really bring savings. And so let's just talk about the types of devices. Bill, maybe you can weigh in on this first. The types of devices that are available for remote patient monitoring. Are SIM cards used? Is it Bluetooth? What happens if I go home with, I'm diabetic CHF and I go home from the hospital? What can you give me, Bill?
So Karen's going to take care of all of that through Trinity Health and their expansive network.
I know
but so it depends, right? It depends on what the clinical use case is, what the conditions the patient has. So typically, the devices that are most widely used are weight scale, blood pressure monitor, and pulse oximeter. But glucose meter, thermometer, peak flow meter, now even EKG, stethoscope are all devices that are integrated into remote patient monitoring solutions for longitudinal care over time. Another thing that we're seeing is with the hospital at home program. So CMS started the hospital at home program, a formal acute hospital at home program about a year ago. And that has been widely and quickly adopted. Almost a hospital a day has been joining that particular program, but many hospital systems across the U.S. have their own hospital to home program. So the patient comes home from the hospital a little earlier than normal. They get some real acute care, 3 to 7 days, and then they move to a more traditional RPM program. So they might have continual glucose monitoring, continuous pulse ox, for a short period of time, and then move to other devices. And then, we're seeing new devices all the time. We're seeing and the advent of patches that give off FDA 510K cleared respiratory, heart rate, et cetera, other parameters. We're even seeing watches, been around for a while, Fitbit and everything, Garmin, all of those been around a while. We're now even seeing rings that people can wear a ring to give off biometric information. So that delivery model's all over the place.
So who's going to be reviewing all this data that comes in? Is it going to be artificial intelligence with triggers on certain levels of alerts? I mean, most practices don't have anybody who's doing something like that. So are large practices, maybe internal medicine, going to become more involved in this and hire specific staff members?
Well, I think that's a perfect opportunity to jump into the Trinity Health at Home Virtual Care Center. We are reaching out to providers outside of the Trinity network and talking with them about really that being a service line unto itself, and opening portals that are non-Trinity portals to kind of monitor patients of cardiology groups and other home care agencies, to really expand that, because I think that that's really what sets us apart and makes it a best practice. Is it's not a medical assistant monitoring those alerts and then handing it off to the provider. There's a nurse who is then scheduling a virtual visit with the patient to make sure this isn't a misread, make sure that they didn't put their Thanksgiving turkey on the scale, and just to make sure. So they're having a virtual visit, they're doing an assessment, and then they are reaching out if an intervention is needed. So I hope that's where we head.
Yeah, go ahead, Rob.
Yeah, I'll throw in an anecdote, right? So maybe 10 or more years ago, I was working at a big hospital system in the Northeast, and we had a CHF program, and we did diabetes and weight and other monitoring. And local news station, CBS in Boston, wanted to interview a patient. We had this wonderful woman named Joan Peterson. And I'll never forget the last part of the interview. It was totally unscripted. We couldn't have scripted Joan even if we wanted to. And the reporter asked her, said, how do you feel about taking your blood pressure readings at home? And she said, well, in a great Boston accent that I can't imitate, right? Sometimes I have to be my own doctor. No one else has been in this body for 80 years except me, right? Mm-hmm. And so in the discussion of remote monitoring and connected health and all these other technologies, it's important to acknowledge that most people care for themselves most of the time. And the function of these devices is to provide them with data to make them better at self-care, or to help their family, their friends, their whoever it is that's in their care team, really help make people better. So from my perspective, the first line is always providing information in a digestible way to the patient to help them achieve their own health goals, whatever they may be, and then to rely on those other systems, the nurses, the dietitians, the register, the diabetes educators, the clinical pharmacists, the rest of an expanded care team to jump in just in time when necessary. To me, that's when the systems really work their best. And I think until you threw AI in there, and we can't really have this discussion without AI, until we reach a point where artificial intelligence can do the triage that today, again, my own opinion, right? Only some really, really good nurses. Some of the telemedicine nurses I've met in my life are just the greatest human beings. They just can connect with people in ways that other clinicians can't, right? Mm-hmm. When AI catches up to them, then I think we'll see that AI triage will probably have to get there to get to the scale we want to. But in the meantime, there's an awful lot of self-care happening, informed by data, and assisted by whatever level of professional, right, is sort of needed at that time. And that's really where the systems, when we look out from him, the systems that we see working well work at their best.
Something you mentioned, Rob, I'd like you to follow up on. You mentioned parity. And so the issue of reimbursement for virtual visits is one thing, and that may be done away with as time goes by, but at least to my mind, the idea of the return on investment for remote patient monitoring is like a slam dunk. If you can keep just a few of these people out of the hospital, it's amazing. But the question is, who's going to pay for it? And aren't the reimbursement models different all over the country?
Yeah, I mean, I think we have a few big reimbursement bucket differences. Again, you have a lot of private insurance, you have Medicare, you have Medicaid, and the different nuances with Medicaid around the country, it being the big three. Right, there's also direct government care. There's the VA and what the VA has done for decades with remote monitoring, what some more closed systems like Kaiser do, for instance, right, with a big captured insurance segment, what they do with remote monitoring. So the incentives differ. I think at the end of the day, there's a couple of big things that have driven this and will continue to drive it. Number one, again, back to what Karen opened up with, right, was for those systems that bear their own cost of care, think the VA, think a lot of Kaiser Permanente, think some others, that benefit of keeping people out of the hospital, reducing hospitalizations, reducing readmissions has always been there. That will continue to be an important incentive for certain conditions, COPD and HCF being the big ones, but I think there are others. There's a host of private insurers who have tried to look at kind of incentive payments or population health payments that can make RPM viable. I know some of the programs I worked on in my own life had private insurers say, we will pay your clinicians and clinics a bonus at the end of each quarter, whatever period it went, for a population of hypertensives kept under a certain average blood pressure, or a population of diabetics with an A1C kept below a certain level. And people who are on the hook for incentives like to be able to monitor what they're going to get for planning. So RPM begins to make more sense in those things. Medicare seems to be the big laggard, but the good news is, and here's where the terms we're using really matter. Most people and most of the world colloquially say telehealth, and we include remote monitoring in that.
Yes.
For Medicare, telehealth has a very specific, very narrow definition with a host of restrictions, and remote monitoring is separate from telehealth under Medicare, right? So in the most recent few rounds of the physician fee schedule, we're starting to see new codes come out that allow for reimbursement for the activities surrounding remote patient monitoring, whether it's a one-time equipment reimbursement fee, whether it's a chronic care management fee for looking at this data 20 minutes per month per patient, and a host of other one-time or ongoing fees that are out there. And I think, to me, that's the biggest breakthrough of the last few years, is that Medicare is starting to catch up now to where some private payers were, some more captive systems were, making the economics of the reimbursement side work. And I'm sure Bill and others are much more familiar with the exact codes and how they fit than I can rattle off the top of my head, but it has been a very important change.
Yeah, so Rob, I agree with that. And what we're even seeing in the physician fee schedule proposed rule for 2022 is, in addition to, and CMS calls it remote physiologic monitoring instead of remote patient monitoring, but in addition to remote physiologic monitoring, which is, as you said, separate than telehealth as an evaluation and management code, now they're looking at adding remote therapeutic monitoring codes and having those be general medicine codes, so allowing therapists to bill for that. It's interesting that CMS has said, hey, we know we need to do this, but we don't really know how to do it. So they're seeking comments on that until September 13th. And I just invite everyone who's interested in seeing those codes added to the final rule. Look at the language in the proposed rule and add comments. You can look to organizations like American Telemedicine Association for what they're going to submit for comments for that, which will be out September 1st. And then law firms like Foley's and Nixon Law, who post blogs on what these new therapeutic codes are and what they mean and what CMS should do to make them really usable and expand this use case across the country. Rob, you mentioned a couple of chronic diseases as being really kind of important and central to those codes, and those are chronic conditions. And when we started, we were looking at that 4 or 5% of the population with comorbid or complex chronic conditions that consumes about 50% or more of the total healthcare budget. So impacting those makes a huge difference in the overall healthcare spend here in the U.S. But CMS has expanded the remote physiologic monitoring not only to chronic but to acute conditions also. So we're seeing that expansion. The only other thing that I'd mention is we're talking about fee for service there with those, with CMS reimbursement. And Rob, you mentioned organizations like the VA and Kaiser, UPMC would be another one where they're a payvider. So they're value-based care also. Right. So, and as we see even in CMS, Medicare Advantage programs growing to more value-based care, where are those metrics like reduced unscheduled acute care, whether that's an ED visit or a hospital readmission, improved patient outcomes over time, lower cost, all of those things that have a lot of data from case studies and white papers on remote patient monitoring become the core issue as opposed to what am I going to get from CMS or from a health plan.
You know, we've discussed telehealth from the viewpoint of the providers, from the reimbursers. I'd like to talk a little bit about the patient side of these things. One fear early on was that, especially with virtual encounters when the pandemic struck, folks would have difficulty with the technology. Did they have to download an app? How, you know, what if the sound wasn't right? Just, you know, there was a great fear that technology could not be handled on the patient side. And, you know, I was surprised, pleasantly surprised, Karen, talking to you a couple of days ago, that in y'all's experience, you're able to ship out, I believe it was iPads that are pre-configured for patients to use. Could you tell us a little bit about that?
Sure. They're actually 5G tablets, and it's really a plug and play. And to give you an idea, our range of patients we've cared for, age 25 to 103. Wow. And the average age is 77. And right now we're looking at about 85% of our patients that we have drop shipped from Vivify, our Home Care Connect kits, are able to self-install. So it's very easy. They make it very easy for someone to connect with a nurse on a call to transmit their biometrics. We've also got standing up over these summer months, June and July, 2 proof of concepts using the Go platform. So the individual has a smartphone, not using the full tablet, and we are shipping them Bluetooth devices that they can then use their smartphone to transmit their biometrics daily. And this population is a little bit different than what we have really had success over the years with. This is an at-risk population. So a lot of what you've been talking about with our ACOs, our Kaisers, what could potentially be an option for our VA patients as well. Patients that have had ED visits or unexpected admissions a year prior, and we're looking at heart failure and diabetes in particular to see if with this constant, and Rob, I love that you mentioned self-management, because this is what RPM can do for individuals. They establish this habit of really being aware of what's happening in their body, that they can manage this chronic serious illness for hopefully a longer term of their life, instead of this up, down, peaks, valleys, I'm readmitted, go to the ED all the time. So that's a new way that what we're managing people through RPM, Jim, and I think it's going to be very successful. And we do patient satisfaction surveys, and we're over 90% satisfied with the services we provide with our Home Care Connect kits right now, and patients find it very easy to use. And the only thing we don't explore where we want to is, would you be willing to pay for this privately? You know, they really want to have that paid for as part of their health.
Yeah. Well, you know, it sounds like the more a smartphone can be leveraged in any of these use cases, the better off.
Yeah,
because
I think so.
You know, folks, a lot of folks are used to using those. Well, let's talk specifically in cases of hospice and home health. During the emergency, COVID national emergency that was declared, total parity was not given between virtual visits and physical visits. Physical visits still had to take place, didn't they, Karen?
They did.
Yeah.
You know, in the hospice world, you still had to have a nurse that went out every 14 days. Probably, as I mentioned earlier, where we saw the support was in facilities where they didn't allow anyone but the nurse in. And so chaplains, social workers made those visits. In-home health, it probably really supplemented initially even non-COVID patients in home care were hesitant to allow home care professionals in the home. They didn't really want anyone in the home in the beginning of the COVID surge. So we did supplement a good bit with support from the virtual care center nurses to make those visits, and with really an update to the plan of care and intervention with the physician. So I think that really made a difference to a lot of people. It also made a lot of difference because they weren't having the usual traffic in their homes that they would have with friends, neighbors, checking on them. And so we commonly had in the middle of the night, a patient would press the need to have a video call and just really want to talk to someone, about their anxiety about being alone. So I think it served even in really a social purpose as well as a medical purpose.
The one of the topics I want to touch on, it's in the matrix there on the screen, is the business side of telehealth. And I'm not talking about the providers who are the vendors or organizations like that. I'm talking about clinics and other organizations that have built their payer mix or their reimbursement mix and fine-tuned it over decades. And so all of a sudden, it can be really scattered quite a bit. I've got a neighbor who's a consultant for federally qualified health centers, and they would seem to be a perfect thing, perfect organization to start using telehealth. But he told me they were a little hesitant because part of their really funding came from their internal pharmacy. So they needed people to come fill their prescriptions there, and that helps support the whole organization. So there's all these collateral effects, it seems like, when we start tinkering with long worked out business models. Of course, new ones are coming to the fruition, and that seems part of where we are now is trying to figure out who's going to pay for this stuff. Who is going to pay for it? If you keep a patient out of the hospital, that's a great savings. But is it going to be sufficient payment to a provider organization to do it? That seems up in the air to me. Any thoughts on that, where we are?
Yeah, so I would just say if you look at the numbers that typical readmission runs between 10 and 15,000 per person. Mm-hmm. And if you're an organization like Trinity, where they've reduced those readmissions by half, that pays for a whole lot of remote patient monitoring.
Yeah. Now, it pays for a lot. It's kind of a strange thing. So the hospitals have fewer admissions, and maybe they will get some stimulus or they won't get nicked on reimbursement if they have fewer admissions. But if they're not filling those beds, that also affects them somewhat, because the reimbursement has always been based on filling those beds. So to kind of flip it, and they get reimbursed to have empty beds, it's like the whole thing has been turned upside down.
So I can just tell you that in our early days, that was some of the conversations with the CFOs of the hospital systems. The providers loved the benefits, patients loved the benefits. The CFO said, wait, I got fewer people coming into my hospital. I've got a revenue hole here. Right. So, in the early days before there was any reimbursement, that took a real strategic balance, and either a hospital organization moved ahead because they wanted to have a differentiator. They wanted to be first in the market offering auxiliary services. They were moving into value-based care models. or models where there was some risk, financial risk in managing cohorts of patients. So all of those things kind of work together over time to accelerate the growth of remote patient monitoring. But yeah, there is always some ROI, deep discussions depending on what the organization is, what their goals are, who's the target population, who's the providers, So it's always an interesting conversation.
I think, Jim, if we look, it's very difficult to look at telehealth in isolation. And we've done that because of the way the technology's grown up, right? We've had traditional care the way it's always been. And then suddenly we started to integrate some of these other new devices. But the point really is that I think we've crossed the inflection point where we have to just think, is this one more tool in a holistic healthcare system, right? Typically in healthcare, we can look around a large area for inspiration, right? Chronic diseases are the same here as they are in Europe as they are in Asia, right? We can look at different ways that people are tackling this. When we look at money problems, the United States is an island unto itself, right? We pay for healthcare differently than every other place in the civilized world. And therefore, we're on our own in figuring this out. I would point to a couple of nations who've tackled the problem that you suggested, Denmark probably being farther ahead than most. Some of the other Scandinavian countries, Norway's up there, Sweden's up there, Germany and others have tinkered around the edges. But Denmark basically said, we're going to close hospitals. The goal of a national telehealth strategy is to reduce the number of hospital beds that we as a society pay for. And they did it, right? Those hospital buildings are now doing other things. That could never happen in the United States because of the unique way our very complicated public and private and other payer systems come together. So I agree with you, it's difficult. I agree with Bill and all the things he pointed out. Each institution is going to have to look at this. But we're going to have to solve this on our own. And one of the paradoxes I see happening is all low margin industries are always conservative, right? Healthcare is not unique in that regard. And the way you fight in a low margin industry to offset a changing environment is through consolidation and scale, right? So the United States is facing two problems right now that are sort of opposing each other. We locally prefer our healthcare system not to continue to consolidate into a few giant entities, but without changing the payment structure, we're incenting them to consolidate into a few giant entities that could handle a shift from acute care to home care because they're big enough to weather that storm. And I don't know that we have the appetite in America for the kind of national conversations and planning that would have to happen for us to really have that deep discussion. So I think we're going to see it's going to be a lot of pain and suffering as it changes, right? I don't know if people probably can't see it, but behind me, there's an old cover from an Economist magazine with Barack Obama standing on the front with a syringe in scrubs on the day Obamacare sort of went live. And the caption is, "This is going to hurt," right? I think this next wave of change is going to hurt a lot of people. Unless we can get together and really say, all right, we're going to plan it out at a larger scale than we probably have before.
Well, and I think too, Rob, what's going to force some of this innovation and change is the workforce. We are really struggling in the industry right now to get nurses. We had the great resignation during COVID. Many people leave, professionals leave because they did not want to work in this healthcare environment. And one of the discussions that we're having right now at the nursing level in Trinity is actually the virtual RN. And how can that supplement a lower number of nurses on a hospital unit to care for the same number of patients? So I think that will play into it as well.
Yeah, when we started in RPM, we used to talk about efficiency, right? So in a heart failure program that I worked with, one telemonitoring nurse could handle a panel of 25 patients, right? Once they got to know them and understood their habits. And back then there was a worry that this was a technology that was going to displace jobs. I think, Karen, you're saying that displacement was forced because of other reasons. it may now be able to be seen more as not a savior, but as one of the tools we can use to overcome those employment challenges.
Right. And I think of it that way. I think that's a great way to put it. I think it is definitely a tool that everyone should have in their arsenal.
Yeah. So along with that, I'd say I'm in Texas. So I know here in the state of Texas, we are 30,000 nurses short of what we need to provide care in a non-COVID spike environment. So there have to be technological solutions to help bridge that gap, not to replace in-person care, as Karen said, but to augment and supplement that.
You know, and some of the requests we've had have been in, we were talking before this started about, I live in Michigan and up in the UP in the north, it's pretty isolated. And individuals come to highly populated areas for their health care, but then they go home. But traversing hours to get your health care, they're talking to us about, yeah, we want to put in remote monitoring. We want you to keep an eye on them. We want to be able to do virtual visits. I mean, it really provides a greater access to care for patients, and it also makes them feel like they're still being managed. Not that, oh, I'm at home and I'm out in remote Michigan and nobody really is caring about my recovery right now.
You know, part of the legislation, these big pieces of legislation we see moving through on a federal level, there's almost always a large set aside for broadband internet for the rural areas of the country. And that's really going to be needed for any of this. Wouldn't you agree?
Oh, I would, definitely.
Yeah, I think broadband is an interesting argument, right? Yeah. I guarantee you, if I looked at a network monitor I have running in my house right now to do this call in high definition with my wife also working remotely downstairs, I'm not using more than about 300K worth of bandwidth, right? So you can do high quality voice, video, and other things on limited bandwidth. So broadband isn't necessary for healthcare, but it sure makes it a lot easier, right? The connectivity, we have a basic connectivity problem in rural America. It's not just a broadband problem. You know, most people who have internet access have pretty fast internet access, but a lot of people don't have internet access at all, or they're relying on a weak mobile signal in many cases. And so there is no doubt to get the coverage we want, we're going to have to confront that problem. Broadband affordability, we have broadband problems on two ends of the spectrum. There's an availability problem geographically throughout much of the country. There's an affordability problem for a variety of other reasons in urban and other areas. And one of the things we saw, for instance, when the FCC opened up a recent round of funding available for consumers to offset broadband connections, millions of people applied for that, more than I think anyone expected, right? And we could chalk it up to the economic difficulties of the COVID pandemic and other things. But I think that was a shock to many people to see how many people said, no, I think broadband is necessary and it's something I'm struggling to afford, along with all of my other points. Some of our fellow organizations within healthcare have realized this, right? I think it was the American Medical Informatics Association, maybe 5-6 years ago, who put out a statement saying broadband is or soon will be a social determinant of health, right? Full stop. That broadband is a health issue. And I think we're going to have to confront both the affordability and the availability. There's some hope. The infrastructure bills that are bouncing around between the Senate and the House right now have funding for broadband in all versions that I've seen. And that's another one of those bipartisan agreements. I think we'll get some funding for broadband, but then we'll have to get into the argument of affordability, right? As with many things we do in the United States, we very often kick some money at it without actually saying, could we make some changes that would make it more affordable, and therefore we'd have to kick a little less money at it. So I think the affordability conversation is one that's going to follow soon after any infrastructure bill starts bringing broadband to the, to some uncovered areas.
Yeah, and Rob, we use mobile networks quite a bit, or LTE. And there is a hope and a promise for using devices like this with 5G as it rolls out to give the broadband the bandwidth needed to have high quality virtual visits, telehealth consults, transmit data for RPM into more rural and underserved locations.
There's a perfect example, right? I was at a panel years ago at a Brookings Institution, and Intel and others were talking about 5G and the benefits for healthcare, right? And I'll never forget what happened. There was a guy on stage, and the moderator had set up, well, will 5G revolutionize emergency medicine? And the emergency medicine doctor said, absolutely not. It's not going to do a damn thing, right? They call it the golden hour for a reason. It's not the golden 5 minutes, right? So I think you just said something very interesting, Bill. You're doing a lot of good right now on LTE. 5G is a very expensive technology to roll out for both technology reasons, penetration, the frequencies that it uses, the way it traverses distances and other things compared to longer wavelengths and other things. I'll never forget one guiding principle I have in healthcare that goes back to something that happened in Europe. There was a director of the Scottish NHS, and he looked at an audience of innovators and he said, for the love of God, none of my colleagues are waiting for your next big thing. If we could just deploy the technologies we've had for 10 years effectively, I'd save 1 million lives tomorrow, right? And I think broadband gives us that chance. LTE connections, strong LTE connections are good enough to do most of what we need to do in healthcare, right? And we have equipment already that could be deployed and bandwidth that could already be deployed to do it. And yet, I constantly hear the drum of 5G, which has many, many uses. 5G is a very interesting edge computing strategy, if you really think about it, right? Allowing for faster decisions to be made at the edges of these networks. But for a lot of what we do, right, we were doing it effectively on dial-up modems. We're doing it with episodic small packet data transmission. I was doing it on 2G edge connections with SIM cards and devices years ago. We could deploy a lot of what we have more effectively, more cost effectively, and probably get to where we need to be. And I wish that was a bigger part of the conversations we had as a nation.
We've got time for, I think, one more question if we have time, then we'll do a kind of a quick whip round. But it's very clear acceptable technology is in the market and has been in the market for a number of years. There is a need for this type of healthcare delivery that's been proven. So there's issues around reimbursement, and there's also issues, I would think, around educating providers that what is available and how it would increase their ability to deliver health. So how does the provider education piece? I mean, people can come and listen to you folks talk and say, well, I think I could probably do that, but is there a wider way that education or this knowledge is being rolled out? This is a applicable way to deliver healthcare, or is it just going to seep in slowly?
Well, I would just say, I think anybody you talk to, whether they're in healthcare or not, has heard the word telehealth, knows what telehealth is, has seen commercials on TV about telehealth in the last few months. I know I have. So I think if you start with that kind of elementary education that starts to drive consumer demand, ultimately consumer demand can make a huge difference in what we do and how fast telehealth and RPM are permanently adopted as a methodology of delivering healthcare. So I think that's an important factor.
That's really true. Just how pharmaceuticals are advertised on television, so they can get patients to walk into the provider's office and say, "What about prescribing this for me?" I'm sure patients go in now and say, "Can we do televideo visits?" I'm sure that's being asked kind of frequently.
Yeah.
And
that's what we're doing here, right?
Right.
Why Karen is here talking about what Trinity's doing and their results. So there's, it's webinars like this, conferences that have speakers and presenters, organizations like American Telemedicine Association, whose whole role is to promote these type of interactions to improve healthcare in the country. So I think we're getting there.
Well, and I think what Trinity found initially when we were doing virtual visits from the provider level is they didn't feel a skill at conducting the visit. So they did a lot of training with their physicians on how to really conduct a professional virtual visit. So I think that's happening. And then commercial payers, they push to you via email. You can have a virtual visit for this. So I think that's a way that it's getting out there as well.
Yeah, I think the AMA a few years ago qualified 5 questions that need to be answered before providers sort of get on board, right? And they end up being, does it work? I think we're probably past that right now. Is it safe? We're probably past that question right now. Will I get sued? That one's still open, and there's good debate to be had around that. Will I get paid? We've heard that through Medicare and other things, right? We're starting to figure out the financial models to make it work. And then the final one is, how do I make it work in my particular practice, right? How do I get equipment? How do I give equipment? How do I look at the data? Does it disrupt my workflow? So I think when I first started in this, none of those 5 questions had answers. I think we've answered 3 out of 5 of them now. And we're down to, will I get sued? Maybe some more payment questions, and then how do I make it work in a particular practice? And as the muscle memory builds and some best practices evolve, organizations like ours, HIMSS and AMA and the American Telemedicine Association and others can get that information out there. And then the final part to me is, the final thing is, almost all technologies, when they come out, we take the technology and hammer it around the existing things that we do, right? When the car first came out, we treated them like horses, and we had traffic laws that made them obey the same things that horses and carriages did. Eventually, the world changed to adapt to the automobile. Right now, as Karen said, physicians and others often feel like they don't know how to use digital technologies effectively, and that's because we don't. We're terrible at it, right? Almost anybody who's tried to work through Zoom and other digital technologies realize it's not the same as being in an office, but that doesn't mean it's bad. We're starting to figure out how to interact more effectively through these technologies. I think healthcare needs to do the same thing. Eventually, we'll adapt our practices to the technologies we have, as opposed to trying to figure out how to adapt the technologies to the way we've always practiced.
Rob, I think that you've done a good job of putting a parentheses on the back end of this hour-long telehealth virtual roundtable. I appreciate that. Carol, I'm going to turn it over to you in just a moment, please. I want to thank our guests today, Karen and Bill and Rob. You've made my job easy. Great talking to you.
Thank you very much.
Thank you, Jim.
It's always a fast hour, isn't it, Jim?
It sure is. Yeah.
Obviously want to thank our moderator, Jim Tate, and of course, Rob, Karen, and Bill. So appreciate the conversation, the insights, the liveliness of our hour together. Thank you, the attendees, for showing up as well. Look for an email with a link to this recording. And of course, we look forward to seeing everybody, hopefully again, on our next event. Be safe.
Great. Thanks so much.
Thank you.
Thank you.